Some doctors have expressed an interest in being able to make these hard, soft occlusal splints in their own office, and there certainly is a system in place if you'd like to do that. So quickly, I'd like to take you through the steps. In fact, this is exactly the same way that we make them here in the laboratory. So you're literally going to be doing and receiving the same splint that you get from us. So the upper model has been mounted here in the lower pot, and you can see those stainless steel granules that have been placed around them to block out any undercuts. And then we put that little gasket on top of that, and then the lower model is in the occluform, in the articulator that I mentioned earlier in this tape, and you can see how the two models are hand articulated together perfectly. They're really rocked in there, and that's why you want to take a nice impression, and that's why you want to clean up the occlusal surfaces. And you can see we're opening the pin here, the 3 or 4 millimeters necessary based on how thick of material you're going to use to fabricate the splint. And then you heat the splint material up for a couple minutes, and then it's got a rapid vacuum. And if you watch that part that just happened, you can really see the material suck down and get thin over the maxillary arch. And then you can see the occluform is closed, so the pin's down on the table. So we have stamped the opposing arch in there in a general sense, and it's going to give us that one occlusal stop per opposing tooth. And then this is a little twist drill that gets used in a lab handpiece to cut this off the model, and you can see you just cut. It cuts, right into the model. Our technicians have made so many of these occlusal splints for dentists that they really have figured out the fastest way to be able to do it. So what you're seeing here is actually part of a training DVD that you get if you purchase the system to make these splints in office. And again, I would fully expect that this would be completely done by one of your dental assistants. I don't think, unless you really loved doing this part with your hands, that a dentist would ever actually do. This can be very easily delegated to a staff member who enjoys this type of thing. And it is a fun material to work with. It's not a real difficult material to work with. To make splints, to make occlusal splints in the old days, you had to take typically a clear orthodontic resin, and you would mix it in a cup and roll it kind of into a hot dog and place it over the patient's teeth and let it set. And it was really kind of an amorphous blob when you were done. This, as you can see, already has a shape. There's that Lisco disc being used, and then the inner liner is being pulled out from the soft material. It's in there protecting the soft material until we're done. And then here's one of our technicians using the felt wheel after the Lisco disc to put that nice polish all around the splint. Again, after I adjust the occlusal surfaces of the splint, I don't go back and do that felt wheel because I know the patient's just going to grind on it again. But here they're polishing all the non-occluding sections of it, including that palate area. And you can see there it is. Obviously, it takes a little bit longer than that to do all these steps, but you get the exact same occlusal splint in your office that we make here at the laboratory for a much cheaper price for you. And probably more importantly, you have the occlusal splint ready the same day, within hours. And so if you have a patient who's got acute TMJ pain, you're able to deliver them a high-quality splint within a couple of hours. Here we've got a patient that we fabricated an occlusal splint for, and before we go ahead and insert the splint and make any adjustments and deliver it to the patient, let's take a closer look at the condition on his teeth. This patient is only 27 years old, and you can see we've got some wear here on the lower anterior teeth already. Got some wear on the lower cuspid. As we pull in, you can see there's some chips on the incisal edges of the lowers. Here's the maxillary anteriors, and you can see the ragged look to those teeth as well. And the teeth otherwise look pretty decent. You can tell that he's probably not 60 or 70 years old, but that's a lot of wear for the age group that he's in, considering that he's 27. And I just wonder what it's going to look like 30 or 40 years later. So this is exactly the kind of person who we're going to show this to and say, hey, look, here's what's going on in your mouth. In fact, here we've got him holding a mirror so he can see. So look at that, and look how that upper and lower cuspid come together, which is what they are supposed to do as he slides into excursions. But you can see we've got the lower lateral hitting the upper lateral, which is part of the wear pattern there. We're already into group function. The first bicuspid's hitting the lower first bicuspid, and we check the other side and we kind of show him what it looks like. And you could see there he was biting together, and those were fitting together like puzzle pieces. And there he goes, slides back over, and bingo. We've got the two cuspids hitting each other, and then we've got the laterals hitting each other as well. And, he's going to continue to wear these teeth down. Why not offer him an occlusal splint? Why not offer him the opportunity to save wear and tear on his teeth over the next 20 years? Why not put the burden of responsibility onto him by making a splint for him? And now it's up to him to wear it at night if he wants to save his teeth. And it's not up to us and whether or not we're going to give him the option of doing this. This is an easy thing for the assistants to look out for, especially the hygienists who are spending all that time with the patient as well. So the splint is in, and because it's a hard soft splint, there's literally, I can't think of one time where the splint hasn't fit if you take a good, accurate impression. So we're drying the splint off here with a couple of cotton rolls and then putting articulating paper on both sides. You could use an arch of articulating paper if you wanted to be able to get the anterior at the same time. So we're just making some marks and taking it out. And I mentioned earlier that we want to have one opposing tooth mark for each of the opposing teeth, so an occlusal stop for each opposing tooth. And you can see we've got a few good ones on the one side and not as many on the other side. I can see a couple on the anterior. So using a pear-shaped burr in an electric handpiece, this is a lab handpiece, and this is really an easy material to work with, this acrylic material on the hard soft splints. And I still prefer using a high torque, low speed electric handpiece. Can you do this chair side with a high speed handpiece? Yes, you can with an air turbine, but I just don't like the way that a carbide burr tends to dive into the material at those higher speeds. So I like to really do it slowly. If you've got an electric high speed handpiece, that's fine. You can use it with that, but otherwise, a lab handpiece, and they're not all that expensive just to get an electric handpiece that can sit chair side or sit in your laboratory. If you want to get up and move this back, and take the splint back to the lab to make the adjustment. So we made one more small set of adjustments here, and then we're going to go ahead and check the excursions and see how the splint looks there. Do we in fact have the cuspid rise that we'd like to have? Those cuspids obviously can handle a lot of stress in a lateral direction, and so we're okay, and we'd like to see cuspid disclusion on both sides of this splint. And with the hard soft splints, it's like I said, with the delivery, I've rarely had one that hasn't gone down into place. And if there is one that doesn't seem to want to go into place, we put it into some, I wouldn't say boiling hot water, but some really hot water, and we'll put the splint in there for about 30 to 45 seconds, take it out, shake it a few times, and then push it onto the patient's teeth. And that soft material on the inside will readapt itself around the patient's teeth. So unlike that full hard splint that I talked about that we made for each other in dental school, we have a material that will adapt itself to the teeth, so it's not so much hit and miss like it might be if we were using that full hard splint where it either fits or it doesn't fit. And we're going to check the anterior here just one more time as the patient bites down together for us so we can check and see what the marks look like here. And then we can go ahead and make any additional adjustments that need to be made and then do any additional polishing that we need to do. So we can see we've got some nice spots in the area of the cuspid. Had the patient slide forward and protrusive. I can see some marks going forward on the anterior teeth as well. So this is pretty much doing what we want it to do for the patient. Again, this is a preventive occlusal splint. This is not a patient who's having any problems with his temporomandibular joint. So we just want to keep the teeth apart and have him grind on the plastic if he grinds on anything. This is the Lisco disc. This green disc you see me using. It looks a little bit like a Scotch-Brite sponge that you might use in the kitchen. These Lisco discs are available from us, from Glidewell Direct. I don't know anybody else actually who sells them here in the States, but they do a great job on this acrylic and other acrylics in terms of polishing them. They're not extremely abrasive, and any marks that you've made with a carbide burr from an electric handpiece can be smoothed out rather easily with this Lisco disc. And you can go beyond that if you want. Certainly you can use a felt wheel on a straight handpiece like that and move up and use an acrylic polish if you want to. But one of the things to keep in mind is that the patient is going to be grinding on this surface. So, polishing it to a high shine like it was a veneer or like it was a crown is really not necessary. And you can see there, I really had to kind of grab onto that and pull that out. We make sure the patient knows how to put it in and take it out themselves. And here's my dental assistant, Jennifer, going over with the patient about how to take care of it, how to maintain it, and when to wear it. And we tell pretty much every patient the same thing. We want them to wear it every night and during the day during periods of high psychological stress. If it wasn't for hard soft splints, I doubt I would be fabricating many occlusal splints for my patients like I am today. If the comfort of occlusal splints is what has kept you from providing them for your patients, why don't you do what I do and make one for yourself or make one for one of your staff members and wear it and see how comfortable an occlusal splint can be. On behalf of myself and everybody here at the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.